Hi, good morning, everyone. I'm Dr. Dinesh Loganathan, consultant orthopedics and sports medicine from Chennai. Very happy to connect with you all today. Mr. Ganesan has asked me to talk on return to sports, a sports medicine person's criteria, like doctor's criteria for guiding the athlete to get back to sports, whether we do surgery or not. Okay, so this is my perspective, and most of the sports medicine doctors follow this, but it is not one individual person's decision, as you know. So, moving on to the topic, I have uh, created my topic into six subtopics. Like, first, I will give a brief introduction. What is RTS? That is the return to sports. Second, what is the significance of return to sports testing? Why it is necessary? Why we need to do that? And the next will be how we can guide as a collective team for the athlete to get back to the sports, and what are the standard tests we adopt in our clinic to give a clinical clearance from a doctor's point of view for return to sports, or the assessment methods we do, at least because we spend very minimal time with the patient, and what are the common sports injuries which we need to set guidelines for the return to sport, and some case-based scenarios for interactive discussion. Okay, so the first topic would be what is RTS? So RTS is nothing but return to sport. So it is, we think that it is one common term, but RTS is a collection of many terms. So I have researched and taken this from a journal, from Orthopedic Journal of Sports Medicine. This is a randomized, this is systematic review. So it has include a lot of studies, and out of that, it has collected 29 studies into its criteria, of which they say what is return to sport is playing at least one game for the athlete's respective sport, or the first game played after the surgery. Whether it could be like at a warm-up game, or it could be at the club level, or it could be at the international level also. So the first game played by the athlete after any injury is what most of the studies quote, and this seems to be practical because the player cannot directly go into a competitive level sport, so he has to get into a first sport. So many of the studies have designed like that. I mean, defined like that. And the other studies have told first regular season game or a pre-season game, excluding that warm up and the initial practice. And some has even stated post-season game. And some has told about competitive. They have specified that this much competitive sport they have to play. So all these studies are there. So for us, for all practical purpose, we take return to sports means the first game played by the athlete of his respective sport. So it is a very a simple term. So return to sport is a very simple term. So we cannot just group everything under one topic as return to sport. So we can subdivide this into return to participation, return to sport, and finally return to performance. So return to participation means the athlete might be participating in rehabilitation, training, or even in sport, but this will be at a very lower level, like very basic. So this is done to avoid injuries and just put the athlete to minimal stress so that he will not re-injury. And the second one we called as a return to sport. The athlete would have returned to his or her defined sport. But while reaching that stage, this can prevent a successful RTS for that individual. So return to performance means the athlete should have returned to his respective sports pre-injury level, like how he has played before the injury. That is called as return to performance. So we mostly go between return to sport, like any game, the athlete going to the game, active game at any level. Okay, like playing warm-up games among his colleagues is return to participation. And when the athlete has reached to that level, that he plays elite competitive, and he is forced to do a lot of training that we and he is forced to return to pre-injury status, and that we call it as return to performance. So why all these are important? Um, because the goal of the RTS or the return to sport is to prevent re-injury. So we want the athlete to prevent the injury first. Health is first, and then at the same time we have to optimize performance. We cannot give too much of rest for the athlete. Too much of protection also will reduce his performance. So we have to help him regain his lost skills and confidence. So how we are going to do this? So we are not looking into one particular perspective. So we are going to divide this return to sport into many assessments: physical assessment, psychological assessment, functional assessment, so that it will be a holistic approach. So it will not be just simple timelines, whereas it will be like holistic. Really, the athlete is fit enough to go for that sport. So how we are going to assess all this? So, as I told, it is a collective team decision. It is not one doctor or a physiotherapist or a coach or a player decides. So, it is a collective effort of at least four different people. One will be the doctor who has treated. The second would be the most important, in fact, most important person would be the rehabilitating person, the physio, and of course the coaches and the players. The core team players should accept that this person can be a part of the team, because his underperformance can also affect other players performance and the entire team performance as well. So the other team players also should get convinced. And finally the family family should allow him. Family should think the child getting back to the sport. At the same time, it should not be something under a performance pressure. So it is like we have to take a multidisciplinary approach. So it should be like balance between health and the performance. It should not be like putting too much pressure on the athlete to get back to the sport, or too much protection on health, preventing him to get back to his original pre-injury level. So it cannot be overstated. So we have to define everything in terms of functional, psychological, and physical readiness. So all these things will only give us structured progression. So slowly we'll have to increase the intensity of the exercises. Slowly we can give more complex exercises or more complex functional rehab. Finally, we can give the medical clearance with some key points in mind. So what are the standard tests we do for clinical clearance? Commonly, it is not any sport specific. Commonly, I'm telling, sorry, there is actually no single standard test for each injury. It is a collection of many tests. Many usually key components we think is physical testing. Physical testing in clinic, first we assess for any pain, swelling. The athlete should have almost 90% range of movement compared to the opposite side, and his strength also should be at least 90%. So how we are going to check all this? We can check this in the clinic. Range, pain, and swelling we can check, whereas the strength and stability will be checked mostly by the functional testing, like hop test. It will be like a single hop or a triple hop, which I think the subsequent topics Mr. Ganesan will highlight on all these things individually, and it's going to be a very fruitful discussion for you. So I'm just giving a gist on that. So hop test, balance test, for say for example for lower limb. For upper limb it will be like throwing test, and for checking the power we can use a dynamometer and check the isokinetic power testing. And the sport specific functional testing also we can do for individual sports. Also we can do certain that Y balance test is there. I mean star excursion balance test is there. And agility drills also we can give, like cone drills, shuttle runs, sometimes jump landing mechanics also we will assess based on the specific sport. Like if he's playing a badminton or a basketball, where he has to often jump and land. So we can assess the jump landing mechanics also in ultra slow motion cameras, and the reaction time the player uses. So all these things can be incorporated. And the very important thing is the psychological readiness, whether the because the athlete will not be affected only physically. Once his game is gone, he will be affected. Mostly, it will be fear and his desperation to get back to the sport. So it will be a psychological readiness. So for that also we have a lot of assessment scales. For example, for ACL, we call it as ACL return to sports inventory, and we have a kinesiophobia scales for fear of re-injury, like how the athlete feels whether he will get injured. Because once the injury is there, the mind will tell like you are going to get injured, and it will be afraid. It will, and the athlete will not perform to his best. So, and also the athlete's self-confidence and self-reporting is very important. The athlete should feel very confident about getting back to the sports. So, how we are going to get the all these testing done? We cannot do all these testing on day one. So, initially, for what as doctors, post surgery or not conservative management also. First, we concentrate on pain management, because when there is a pain, muscles won't work. So pain management, slowly we will try to improve the range. Once the range is improved, we will try to improve the strength in the available pain-free range. And slowly we will put the athlete into complex motor skills that you physio guys and rehab guys will take care. And finally, the full practice will be there, and warm-up matches and low level, low intensity games, and then slowly, gradually progressing to competitive sports. So this is the algorithm we usually follow. And for testing methods, we follow physical testing. Functional testing will be mostly by you people like physios and rehabs. And sports specific testing will be by their coaches. And psychological readiness will be by a psychologist, a sports psychologist. And all this will be overall assessed by a doctor, physio, and everyone. So all the things should fall back into one place. And so it is a multifaceted approach, very, very complex approach to getting the athlete back to its back to his original pre-injury level. So on to the next topic. What are the common sports injuries we are bothered about? Say it could be a simple hairline crack, ranging from a simple hairline crack, or it could be sometimes stress fracture, or could be a complex violent injury of a bigger fracture also. But mostly we see a stress. We don't jump in and operate stress fractures. Mostly it is medial tibial stress syndrome or some foot stress fractures. We assess the athlete's metabolic status, his vitamin D level, give some supplements, put him through rest. Usually it will be between somewhere between 6 to 8 weeks. And on examination, he should not have any tenderness, and restoration of normal loading, hop test, and all those things we do. And slowly, gradually, we can allow him to return. So maximum it will be like less than 3 months only for stress fractures. For contusions and bruises, so it is because of bleeding under the skin, violent impacts. So it is mostly a soft tissue injury. So deep bruises alone, we need to avoid violent exercises, passive stretches, because it will cause more bleeding and there is a high risk of athlete developing a myositis. So violent massages should be avoided, and affected area should be rapidly immobilized. Mostly it will be between 3 to 4 weeks. The athlete can get back to his normal level. So the next thing would be ligament sprains. So the ligament sprains, it will be mostly of the lower limb, ankle, and the knee. The ankle sprains, very, very common injury. As you know, that grade 1 is a mild stretch or a microscopic level tear, grade 2 is a partial tear, and grade 3 is a complete tear. Complete tear might require surgeries. Partial tear, grade 1 and grade 2 tears mostly requires rest and functional rehab. So grade 1 tears usually take 1 to 2 weeks, and grade 2 tears takes 3 to 6 weeks of time. Grade 3 tears take a longer time. For knees and knee injuries, if it is a patient is undergoing surgery, it will be somewhere between 8 to 9 months. Sometimes it can be up to 1 year also. Moving on to the shoulder. What is slap? Slap is the superior getting torn from get damaged. So athlete will have severe pain on overhead action. So it is a common problem with overhead athletes, pitchers, throwers, even cricket players in violent throws can get all these problems. So again, slap tear. The rehab is very crucial. Rehab takes months. Some timing is crucial. Timing varies with different injuries with different individuals. So for biological healing, the minimum time frame post surgery would be 9 months. 9 months will significantly reduce the risk of re-injury by 50%. And graft maturation and biological healing usually takes more time, even if the athlete doesn't have any pain and is determined, and he might show physical readiness. But graft maturation time, we need to allow, we need to restrict the athlete, even if he is physically fit. So the physical readiness, as I've told, to assess, we have to assess the range of movement and the strength. As hamstring to quadricep strength ratio, we can use it. And psychological readiness, as I already told, it's ACL. For ACL, we use this ACL RSI questionnaire, and that phobia questionnaire is there. So high confidence in the knee is vital, but the subjective confidence, too much of subjective confidence is also dangerous, and fear of re-injury can impair performance. So all these things should be factored in while guiding the athlete. So we move on to some case scenarios. So 22 years soccer player with grade 2 ankle ligament tear, like partial tear. Mostly it's a non-surgical management. So we do rest ice compression elevation. Slowly we get back the athlete by 4 to 6 weeks with functional rehab. Slowly the order will be range of motion, pain control, and improving the strength, the balance, and slowly it will be like agility, plyometrics, and sports specific training. So the progression and clearance criteria I have already told. It will be like 90% of the pre-injury strength balance should be there, and range of motion should be there, and all the agility tests he need to pass out. So the second scenario would be a basketball player, a throwing athlete. So he has a slap lesion. Type 2, it's the most common. We have a lot of slap lesion types. Type 2 is the most common. Happens because of, as you all know, it's posterior capsule tightness. So how do you manage? So the management starts initially non-operatively. If it is not getting all right, so we take an informed decision. So we do surgery. Surgery can sometimes may not be the only solution, because most of the time slap lesions with proper rehab will get all right. So certain athletes like pitchers, basketball players, and throwing athletes like baseball pitchers, where they have abnormal excess motion, surgery may be required because they do the sport very violently. So the non-surgical trial period would be usually 3 to 6 months of physical therapy. And if you are going for surgery, it is going to be a longer time. As I told you, usually it is somewhere between 9 to 12 months. So we start with interval throwing program around 4 to 7 months, and slowly we progress to continuous throwing. So the progression criteria, as I've told you again, you should achieve a pain-free, passive, full range, or 90 to 95% range and 90% strength compared to the opposite side. And if the basketball player, so we have to avoid placing excess tensile load on the biceps. Avoid resisted elbow flexion and forearm supination during the initial healing phase. And sport-specific training program, as I told you, start with interval throwing and slowly progress. And that's it. So the last case scenario would be a 19-year-old runner with tibial stress fracture. Mostly stress fractures are treated conservatively. Only hip stress fractures we tend to operate. And most of the stress fractures in athletes would be of lower limb because of excessive training. So it will be of tibia, metatarsals, phalanges, like that. So the treatment heavily focuses on rest. So we need to, because the athlete will be able to do certain level of sports in stress fractures, like he will not be completely disabled. So we have to restrict him from going to the sports. So we have to tell him that he has to rest adequately at least for 8 weeks. 8 weeks, 4 to 4 weeks of absolute rest, 6 weeks moderate rest, and after say 8 weeks, we can slowly allow him for the game. And the clearance criteria is usually we take MRI, because stress fractures we tend to miss in X-ray. How the athletes will present repetitive pain along the shin of the tibia. We think that it is a shin splint. We tend to give stretches or do all sorts of releases, cough releases, physical therapy, but still the pain persists. Then we do the MRI and identify that it is a stress fracture. How do we identify? It will be a edema seen. Like stress fracture is mostly like precursor of fracture. So it is just a bone edema. So which means the bone is subject to excess stress there. So we check this edema subsequently after 6 to 8 weeks. And this will be from the doctor's side based on clearing, based on imaging. And after that, the physio and the rehabs and the coaches will take over the functional test as already highlighted. So to conclude, we have to prioritize testing. At the same time, it is a collaboration from the entire team of doctors, physio, coaches and the co-players and the family members. So testing will be the like initial stage, like the doctors test, find that the athlete is fine, he is not having any pain and he is having good range, good strength, fine. And after that, whether he is fit to go for the game, a doctor cannot go and check, do the hop test, do the excursion test like that. So it will be like mostly by the rehab professionals who has rehabilitated, and secondly, it will be by the coaches who do the functional and agility sports specific functional testing before taking the particular athlete for the particular game. And also, we need to quickly evaluate the seriousness of the injury. Like we need to create a psychological readiness for the athlete. Like stress fractures, we need to restrict the athlete. Uh, ACL surgeries, we need to restrict. After 3 months, they will feel normal, but still we'll have to tell that graft maturation time is somewhere between 9 months and 12 months. So you need to reinforce, restrain the athlete from playing. Otherwise, he is going to come back again with an injury. For mild and moderate ankle sprains or any ligament injuries, we need to rehabilitate, send the patient athlete quickly to sports. So sometimes psychologically can go back to the game. Athlete will be more afraid and he doesn't want to go to the game. So it is like either ways. So we need to counsel the athlete based upon the condition regarding his psychological readiness, and the monitoring will be an ongoing monitoring. It is not a one day, one time assessment. It is like a multiple time, multiple people will assess, and the assessment, as I told, it will be like initially by the doctors, but subsequently it is taken over by the physios, rehab professionals who has rehabilitated the athlete, and finally the coaches and the co-players. And towards from the beginning to the end, the family will be there in all the facets of athletes return to sports. So I hope that this talk has given you some idea what as we doctors do regarding rehabilitating the athlete after an injury, and getting him for giving me the opportunity to talk to this elite group of physios who are very young, energetic, who wants to do something for sports medicine. For you, have a nice time. Thank you.
Thank you, Dr. Dinesh, for your valuable inputs. Thank you very much.
Thank you.